Welcome, everyone. Can you hear me okay? You can't hear me? Okay, well, I'll talk a little bit louder. So welcome, I'm Joel Alone from the Center for Community Studies at JCC, and it's my pleasure to have you all join us for our first event that we've held here at the Nest at the Strand. And before I introduce Dr. David Larsen from Syracuse University, our keynote speaker this evening, I'd just like to mention how proud we are at the Center for Community Studies to see this presence downtown that we now have, and how excited we are to have our future civic engagement program speakers, hopefully all here. And we couldn't do it without the generous support of the college and the College Foundation. And then there are 2 or 3 local groups that sponsor us each year that certainly deserve to be mentioned as well. The Development Authority of the North Country, the Northern New York Community Foundation, and the Lewis County Board of Legislature. So David Larsen is someone I met in 2019 when I did my latest sabbatical at Syracuse University, right in the midst of the pandemic. And David and I were kind of connected via some friends in the sports analytics department down there. And we found out we were both math geeks. And little did I know how much I would learn from David about public health as we were applying the math and doing the modeling. I'll let David introduce himself a bit more, and I really look forward this evening to learning more about what we've learned from the COVID-19 pandemic. Thanks for joining us, Dave.
Thank you, Joe. Thanks for having me up here. It's quite an honor to be invited by the Center for Community Studies in SUNY Jefferson. What a beautiful venue to be here. Thanks for spending a Thursday evening with me. I hope what I have to say, back up a bit. I hope what I have to say is okay or at least entertaining at some point. Maybe you can learn something, or I can learn from you. So my name is Dave Larsen. I'm a professor of public health from Syracuse University, and my career has focused on infectious diseases. In the beginning, I worked a lot on malaria. It's a mosquito-borne parasite, and I was very interested in, can we get rid of malaria, eliminate it from transmitting in the community, and then confirm that it's not there. And so I started working on what's called elimination and then surveillance. And the surveillance is making sure that infectious diseases are not circulating. So today I want to talk about our infectious disease surveillance systems. We use COVID as an example because it was very recent, and talk about a few more things. And to start, we can compare 2 recent pandemics. And so COVID-19 is a pandemic that's super, super disruptive for all our lives. A few years previous, we had a Zika pandemic. And Zika virus is a mosquito-borne virus. And its characteristic, it was first noticed by these children born with microcephaly, where their brains and their skulls were underdeveloped and they're handicapped for life, basically. And then COVID-19 was first noticed by clusters of pneumonia hospitalizations. And these started in October, November of 2019 in Wuhan, China. People didn't know what is this. And the scientists, the medical doctors there thought that it looked like SARS, which was a coronavirus that emerged in 2003. And that's kind of where the understanding began. But when we think about these 2 pandemics, this one on the left here, that's a baby born with microcephaly. And I guess it's your right, the one on the right. And then the one on the left, this is one of the hospitals that was built in Wuhan within weeks. And they weren't treatment hospitals, they're not the same as like a SUNY upstate. These were quarantine centers and isolation centers for people who were sick and meant to try to slow and stop the virus. So I'll come back. So both of these began with these unexplained clusters of unexpected disease. In Wuhan, China, they were clusters of adults with pneumonia that were hospitalized. In Brazil, the Zika pandemic began, or was first noticed, when these clusters of babies being born with microcephaly at rates that were higher than was expected. They're 2 very, very different modes of transmission. COVID-19 is airborne. Zika is transmitted through mosquitoes. And this is the Aedes albopictus mosquito here. It transmits Zika, dengue, yellow fever. It's now invaded New York State. So with climate change, we may have more of these viruses. But because these modes of transmission, those mean there's very different risk profiles for who's at risk and how the people around the world experience these pandemics differently. I guess I need to back up a little. So with Zika, we know where the mosquitoes live. And if you live where the mosquitoes are that can transmit Zika, that makes you at risk. So if you live in the North Country, where we are, up here, right? These mosquitoes here are not likely to be found or have no risk of Zika. This map shows the distribution probability of the mosquitoes that transmit Zika, where the red areas are 100% probable to encounter those mosquitoes, and the blue areas are 0. So up here, we don't have to worry about Zika. That's our experience. And our public health doesn't have to respond to Zika locally. When we think about our public health response, it depends on if we plan to travel to areas that could potentially have Zika, and that's it. We don't have to worry about people coming back. For COVID-19, because it's transmitted through the air we breathe, then we might think about being at risk. This is a map of flight paths across the globe. Every line is a different flight path. I believe this map's it might be from 2020, 2018 or so. And so you can see how connected New York State is with Europe, how connected Seattle, Washington, and the East Coast is with Asia, and then how connected Europe and Asia are. And this becomes the risk for potential importation of a respiratory transmitted pathogen like COVID-19. Because the understanding differs, the response is different. With Zika, the understanding of where Zika was, and then most importantly, where Zika was not or could not be transmitted because the mosquito's not there, that allows for geographically precise public health interventions. That allows the community to say, we're not going to intervene because we don't have to intervene. Or allows for people to say, I'm really not worried about Zika because I'm not at risk. COVID-19, we didn't have that same geographically precise public health intervention. COVID-19 could be carried by humans anywhere, and so that required geographically broad or broad generalized public health interventions. And it's just, you know, what's happening in New York City might affect what happens here in Watertown, in the North Country, or wherever it might be. Now, scientists, we have warned about the threat of pandemic infectious diseases for decades. These are stills from a movie that was released, I think, in 2010. Does anybody know the movie? You got Matt Damon right here, Jude Law over here, Kate Winslet or Hudson, one of the Kates, I don't know their names, right? This is the movie Contagion. And I say that COVID-19 was so predictable that they wrote the script in 2010 and they published the film Contagion. Why was Contagion so accurate, right? Why was this movie so accurate in predicting how COVID-19 would spread? Is because this film was based on the 2003 coronavirus outbreak of SARS. Now, COVID-19 is the disease for SARS-CoV-2, Sarbeco coronavirus 2. There is a Sarbeco coronavirus 1. They didn't put the 1 behind it because it was the first one, and that's SARS that broke out in China in 2003, spread to South Korea and some other Asian countries, but was thankfully cleaned up. We didn't have a risk of SARS here in the US. But between 2003 and 2019, you have this great expansion of Asia-American travel and a great expansion of travel from inside China to the outside of the world. So those population dynamics have shifted, and the risk of spread from these they're called hotspots of viral emergence, areas where we know people are encountering viruses in the wild a lot. The probability of that spread increased. But this movie got everything right about COVID-19. The one thing they got a little bit wrong was Jude Law, his character. He was the denier and the man that sold the fake medicine. Right? We know, the scientific consensus is that COVID-19 emerged from likely a bat through an intermediate animal into humans in the Hunan market, right? All the evidence suggests this is the most probabilistic and simplest explanation for how this virus came about. The lab leak theory is possible, but it's not likely. It's just it's the least probable scenario. Bats have a very unique immune system. They harbor sarbecoviruses similar to SARS-CoV-2, right? The first SARS has been implicated to come through what's called a civet cat. And that's where they think that it emerged through the civet cat, and then it gets into the humans. The civet cats are the animals that are found in the regional food markets, and that's the intermediary host. There was a second coronavirus spillover event called MERS, Middle Eastern Respiratory Syndrome. And that's known to come through the camel. And that was 2010. So SARS-CoV-2 was the third coronavirus to spill over from humans. It wasn't a secret that this could happen, right? This is what people like me study, and it's just what the science knew. And so SARS-CoV-2 emerges. The pangolin was implicated. I kind of hoped that this was the intermediary species because this animal is the most trafficked animal in the world, and the human activity has almost driven it to extinction. And then we can call the pandemic the revenge of the pangolin. But I think the current thinking is that it may not be through a pangolin intermediary, it might be a different map. This map here is a map of all the different cases, right? This is the city of Wuhan on the Yangtze River. The Wuhan Institute of Virology is right here. All of the initial cases are clustered around the Hunan market, where they found the RNA for the SARS-CoV-2 in animal cages all over that market. And so this is part of the evidence that suggests all this cluster of cases around the market, that's where the spillover events occurred, and that's where the pandemic began. So a farmer would have brought an animal to market that was infected. That animal picked up the virus from a bat, might have transmitted it to other animals, and eventually got into humans. That's the way that influenza emerged during the 1918 pandemic of influenza in Kansas. It came from the wild animal reservoir to the domesticated animal reservoir, and then spilled over into humans. And it's a very much a known, it's a known route of emergence for infectious disease. Once it emerged, it starts to spread. You might see similarities in this map with the air flight travel map. This map is a genetic map, where the colors, if they're more similar to each other, then the SARS-CoV-2 viruses that have been sequenced are more similar to each other. So here's like the viruses that are circulating in Asia. Some of those start to export along known flight paths into Europe. And then they start to spread, and they mutate differently from their cousins in Asia. They become yellow. And then they spread over here to the US. And they become different from their cousins in Europe or in Asia, become red. And the colors are just saying they're different families. What happens? We have 20 million global deaths in 2 years, long-term sequelae among survivors. And everybody lost during the COVID-19 pandemic. Everybody, even people that didn't get sick. You know, my daughter, she lost a birthday party, and it's not trivial. It's real. These are real losses of our humanity during this pandemic. Some due to the virus, some due to our response. Right? I wanted to share this slide, and this is the right slide deck, Joe. We were wondering when I saw one of the slides. I wanted to share this slide because recently I've heard that COVID-19 is no worse than a cold, and that infectious diseases are just around, right? Every year, scientific research comes out to understand better the linkages between infectious diseases and long-term complications. So just this week, we found out, or a study suggests, that if you have a COVID-19 infection, it increases your future risk of infectious disease. This is a really cool study where they took veterans in the veteran health system, and they had people that got tested on the same day, those that tested positive, those that tested negative. If you tested positive that day, you got a 20% increase in all these infectious diseases over the next 2 years. Another recent study this week that I read was about shingles vaccine, and that it reduces the risk of dementia. And so shingles might be implicated in some of our dementia burden. And this study was very clever. They used, it's called a regression discontinuity. And what that means, that's a technical math term. But they had a policy in Wales where you're eligible for shingles if you were born after a certain date. So they looked at the risk of dementia among people born before that date, who, you're born before January 1st, 2025, different than born January or December 31st, 2024. Like, that's just one day. So you look at the people born just before that date and their risk of dementia, and the people born after that date. And they found that yes, shingles vaccine likely reduces the risk of dementia. And this study is a few years old, but it is groundbreaking. And so multiple sclerosis is now thought to be caused and triggered by the Epstein-Barr virus. And most people in here have had that Epstein-Barr virus. It's a very common virus. They were able to find, again, with veterans, and they use veterans a lot because of the health records that veterans have in the VA. But they were able to find people without exposure to Epstein-Barr and with, and then the risk of multiple sclerosis. And so every year, we learn more about what these infectious diseases do, not just for when you get acutely sick, but long-term consequences. And it increases the impetus, in my view, to try to control them, maybe even get rid of them. Right? And so my work focuses on infectious disease surveillance. And I like to think about public health. Another term that's kind of used is health security. And if I could give a definition for health, I would say health is freedom. Health is the freedom to do what we want to do, how we want to do it. And if we're not able to do that in certain ways because of our body or our mental health, then we have a poor health. And so public health, health security is maximizing that freedom. Underpinning that is this system of infectious disease surveillance. We largely ignore because as long as it's working, we're as free as can be, and there's no worries. Once we start to lose our health security, then we start thinking, all right, our infectious disease surveillance system is good enough. Infectious disease surveillance has two purposes. Well, first, let me define it. Public health surveillance is the systematic and continuous data collection for public health benefits. So we're continuously collecting data to understand what are the trends of infectious diseases in the community, where they are they growing, are they diminishing? Right? And there's two purposes. First, we need to confirm that a community is safe. And our infectious disease surveillance systems don't do this very well. The second is we need to alert a community to an increased risk. And that's where we have focused historically our infectious disease surveillance systems for that second point. Right? And this is an example of how. This is a time series from January 2020 to December 2020, the number of COVID-19 tests done across New York State, going from 0 with the first beginning in March to more than 250,000 per day we were doing at the end of 2020. This to me represents a heroic public health response to COVID-19. It also suggests to me that there are inefficiencies and improvements that can be made. So the genetic sequence for COVID-19 was released on New Year's Eve 2019, December 31st, 2019. The diagnostics were developed in January. And once you start having the diagnostics developed, you have to manufacture them, ship them, get the system to test the people, get them tested. And so you have this slow ramp up of clinical testing ability. We shut down in New York, and maybe you remember, March 20th, 2020, the school shut down. I'm the father of 4. All 4 kids were home, trying to do Zoom school, and life was miserable. We started in 2020. In my county, in Onondaga County, we had to wait until May before we could get a clinical test. That's when anybody could get a test. Before that, they turned you away unless you had contact with somebody that was with exposure and travel in relation to China. So this whole time, COVID-19 is spreading in New York. This here is a map of our wastewater treatment plants across New York State. There are 600 municipal wastewater treatment plants. 200 of them serve 95% of the population. And so where previously we're trying to scale up to 250,000 tests per day, how quickly could we scale up to 200 tests per day? Now, why would we want to test wastewater? Well, what comes in the body goes out of the body. COVID-19 comes in, it comes out, and you can test the wastewater for evidence of COVID transmission in the community. So one test, you get a representative sample of what's happening within that community. There's some other benefits. Everybody poops. Not everybody poops in the toilet, but everybody poops. And more people poop in the toilet than have access to a COVID-19 test. So the data we get from the wastewater is more representative than the data we get from clinical tests, right? It's low cost and convenient. It's non-invasive. There's a lot of good things. So in 2020, I set out to build the state's wastewater surveillance network. That's what I could do during the COVID-19 pandemic. Our first step is we had to map what are called the sewer sheds or the wastewater treatment plant catchment areas. This didn't exist until we created it. But these blues are all the treatment plant catchment areas that we mapped. And here's Watertown's right up here. So we mapped these out. That was the first step that we had to do. We had to build this surveillance system infrastructure. We then had to build the reporting tools. We needed a dashboard. How could we communicate the data to the people that needed it? How could we communicate to the public to let them know that, hey, COVID-19 transmission is really high in your community. Maybe you want to stay home, maybe you want to wear a mask, or more importantly to me, maybe we can get the kids back to school because COVID-19 transmission is really low in this community. And maybe we can go visit some people and get out of our house because we're going to kill each other. All right. In our scale up, we reached every county in August of 2022. Almost 200 treatment plants by 2023, and they test weekly. 95% of the sewer population in New York is covered, and about 80% of the population in New York is on sewer. These graphs show some of our accuracy. I don't think I'll go through them. I can talk about them if you'd like, but this one I really like is the time. We take a sample, a 24-hour sample of the treatment plant. The wastewater treatment plant operators, they take these as part of their job. So they give us one of their samples that they're normally taking to test for E. coli and other things. It gets shipped to the laboratory, and within 3 days, we had 95% of the data ready for the public. And that turnaround is way faster than in a clinical test. Now, I started on this because I wanted to get my kids back into school for COVID-19. But I quickly realized that because the system needed to be built, we had to build confidence in the system for it to be used, that it would not necessarily inform the COVID-19 response, that we were building something for the future. That future came really fast. In 2022, we had a polio outbreak downstate. And this is a map of the counties and their wastewater where we found polio in the wastewater and linked it back to that case where one fellow, he had paralysis from polio. We estimated that one case represented 10,000 infections across 5 to 6 counties. And so very early on, we used the wastewater surveillance network that we built to respond to something that I never thought that I would see in New York State. Mpox was that same summer of 2022, and that one broke out. We started pilots of influenza, RSV, hepatitis A, and norovirus. 2-year pilots are just now finalizing the analysis on these. And this wastewater will help us model or predict how many hospitalizations of influenza will be happening in the next week. And you think about if you're staffing a hospital, how valuable that information is. We already do it for COVID, but we'll add influenza, we'll add RSV. We're working on antimicrobial resistance, and then we're also working on measles. And this is why I thought we could get my kids back in school, is this idea, can we prove the absence of infectious disease risk? Now, this is the goal, to confirm that a community is safe. If you don't detect a pathogen when you look for it, how confident are you that you didn't find it because it's not there? Or how confident are you that you didn't find it because you're bad at looking, right? And some people are bad at looking for things. I've been accused of that before. So if we don't detect the pathogen in wastewater, if we don't find it, we don't find COVID-19, we don't find measles, we don't find polio, either that community is free from the disease and can just do whatever they want, they don't have to worry about it, or our system missed the pathogen. Those are the only two options. Now, this is impossible to prove. Science cannot prove an absence of something. If you said, can we prove that there are no pink unicorns on Earth? No, we can't prove that. All we can say is that for as long as we've looked, we've never found them. But we can quantify the probability that our looking missed that. And so what's the probability that our wastewater surveillance missed a pathogen? And then we can use some math. Well, we'll get to the math, I guess. And this freedom from disease, where does it come from? It comes from agriculture. And so if you're a rancher, or if you have a herd of animals, you want to bring those animals to market, you want to make sure that those animals don't get sick. And the only way you can make sure it doesn't get sick is if your neighbors also, who are bringing animals to market, their herds are healthy and are not getting sick. So in the agricultural world, we have a surveillance system for infectious diseases. That's clinical diseases in animals, butcher inspections, herd surveys, and they all answer this question, are animals safe to bring to market? And if they're not, we close off the market. We've done this with beef from the United Kingdom with mad cow disease. We've done this has been done with pork between Europe and Africa with African swine fever, right? So there's a huge economic loss if you import an animal that has a disease. So then you develop this science around freedom from disease and about the confidence that a community is free from that disease. And sometimes it's called the freedom from infection. It's been hypothesized that we could use this for all these diseases we're trying to get rid of. Malaria, measles, rubella, guinea worm, right? It's never been shown to be used in real public health practice. I'd still like to see it to be shown. And so we thought that we could use this for COVID-19 using the wastewater surveillance. So we took data from 2020. This is our system. This was a state network in 2020. Colleagues at SUNY Buffalo, they were testing over in Buffalo. All these folks were shipping wastewater here to Upstate Medical University and Quadrant Biosciences to test with my team. And then this one here's Watertown working with us. We had about 1,500 samples that we tested. And the wastewater tests that we were using was really quite cool. My colleagues at SUNY ESF and Upstate, Hyatt Green and Frank Middleton, they couldn't get the supplies. Like, remember how people couldn't get toilet paper? Well, the scientists couldn't get the supplies to do tests. So they discovered a new system that used table sugar. They call it the sucrose cushion, a 50% sugar syrup. They put that underneath the wastewater and they spin it down, and all of the nucleic acids, the RNA and the DNA, form this pellet at the bottom. And they pull that out and then they do a PCR test on that pellet. So we categorize these test results into three: not detected, detected below the limit of quantification. So we think it's in there, but we're not confident about how much is in there. And then quantifiable, where so much is in there that we know we can measure how much it is. We matched that up with our clinical data. Right? The State Department of Health, they gave us COVID-19 cases that were geocoded to the wastewater catchment areas. And then we also were able to see if that specific case was on public or private sewer systems. And we get to our math. If we don't detect that SARS-CoV-2 in the wastewater, either that community does not have COVID transmission or our system is bad. So we quantify this probability, and we estimate the sensitivity of our surveillance system to find one case per 10,000. And that's what we estimated, that the system could identify. It started getting positive hits with 1 case per 10,000 population. And the number of consecutive tests where it's not there increases our confidence that the community is free. So here's the context of where we're at. This is the early days of the pandemic. We're going through May to December. So we have really high transmission. We start the Flatten the Curve campaign. Transmission comes way down to the summer. People get restless. Thanksgiving comes around. And then people, and the New Year and Christmas and Hanukkah holidays start to ramp up. Here's what the case data look like. You can see how badly this is. This is test positivity, or the percentage of tests that were positive. And these are the cases. So we had more cases in December because we were testing more, fewer cases in April because we were not testing as much, but transmission was higher in April. And this is my favorite figure over the last 5 years. So I'll take some time to explain this because it is complex. On the x-axis is the number of cases per 100,000 population when the wastewater sample was taken. Those have been categorized into, at the time, the CDC had a measure of low, moderate, substantial, or high transmission risk. So low was 10 cases per 100,000 in the previous 7 days, then you're at low risk. Moderate was 10 to 50, substantial 50 to 100, and high was greater than 100. These different categories are wastewater results, not detected, detected below the limit of quantification, and quantifiable. And each circle is a wastewater sample. Right? And this is a box plot where this thick line is the median. This box is the interquartile range, or you go from the 25th percentile to the 75th percentile. And then these horizontal lines are the range. So you see where the medians line up. If we're confident in measuring the number of SARS-CoV-2 RNA particles in a sample, on average, we can say the transmission is substantial or high. If we detect it, but we're not confident in detecting, in estimating how much, on average, we're here in this moderate range. And if we don't detect it, on average, we're here in the low transmission, low risk area. And so we have almost, and this is pure like serendipity, we have an almost tailor-made risk stratification for the public and the ability to communicate what the risk is. The CDC at the time was recommending for low communities, you didn't even have to wear a mask. If it was moderate or above, that's where they were recommending mask wearing. Right. This is for test positivity. New York State had such good clinical testing and testing numbers that the test positivity was always really low. So we just looked at the incidence of case data. Now here's 2 case studies, 2 very remote communities. You might be familiar with Auburn, New York, and Canandaigua. Is it Canandaigua? Auburn, New York, and then Cortland, New York. Both of these communities had a lot of non-detections of COVID-19 in their wastewater in the summer of 2020. This is Cayuga County, not Canandaigua. So here's Auburn. We started testing with them in May. Every week, we did not detect the virus. Every week we were detecting the virus starting in May and June. And so our probability that our confidence in being free from disease is 0, as long as we're detecting the virus. The first time we get a non-detection was late June, and our confidence boosts up to about 20%. Good thing, because next time we detected the virus and it's back. Then in late July, we start this string of non-detections, right? And our confidence that we are safe from COVID in this community grows up to almost 85%. Here are the cases countywide in Auburn. You have a cluster, a temporal cluster here of cases, another temporal cluster here, and you have all these little cases that don't really form a cluster until the school starts up in September. And this whole time period, there were like 6 cases of COVID-19 in the county. Not in the county, I think it's in the sewer shed. And so from there, we could have said, maybe we're confident that risk is low. And does that change the pandemic response during the summer of 2020? For Cortland, we started out not detecting. We did not detect COVID-19 in the wastewater of Cortland until mid-July or early August, right? And that was our first detection. And we did not have cases in Cortland until late July or mid-June, the first few cases. And we worked with the treatment plant operators. These cases were not on the sewer system. And then we had our first cluster that coincided with our drop in confidence. And then this here, more sporadic cases. And then this is the SUNY Cortland outbreak. The pandemic response in these counties could have been, with confidence, we don't think we have COVID in your community. Be safe, limit your interactions, but be human. Maybe don't travel outside the county, maybe decrease the frequency of your visits, but maybe you can use the playground, maybe visit grandma, maybe don't just isolate in your house. And that could have been data informed and locally informed. And that would have, in my view, that would have changed the trajectory of the pandemic and prevented some of the social fracturing that we've observed with the response to the pandemic response. All right, gonna finish up here in a moment. I wanted to mention polio and how this works in polio. So these are the counties where we detected polio in the wastewater. Each of these circles is a wastewater treatment plant. And the darker the circle, the more frequent times it was detected. And so could we confidently tell a community that there's no polio transmission in your community? So we do all this math, right? We estimate, here's the freedom from disease. We got to figure out what's the sensitivity of that. We see that the sensitivity of wastewater is a function of the coverage of the population, the temporal coverage, and then the sensitivity of detection. Well, how sensitive is this test? We tried two different ways to estimate it, one based on a shedding model from another study, another based on our own model paralytic, or our own model polio transmission. And then we get this magic number 0.63 as our upper limit of poliovirus, our poliovirus infections. And I'll show you how that informs. So here, across the state, we presume that we have a very poor sensitivity to detect polio in wastewater. It's, for odd reasons, it's not shed as much as COVID-19. So most of the state, we're less than 5% sensitive, right? We're not confident if we don't detect it. What that means is if we get 3 consecutive non-detections, we're still not very confident about how many infections there might be of polio in the community. Some of these really small communities, we're confident with greater than 80%, but most of the state's much larger than that. But we can flip the public health messaging and say, well, we think there are less than 25 infections across the state. And that's the actionable data, right? So with polio, most of the infections are asymptomatic. Less than 25 infections we're not so worried about, as long as that number is not growing. Down here in New York City, the wastewater treatment plants are really big. It's hard to find one infection in a giant city. So it's just it's less useful for New York City, more useful for small communities. Okay, this is just at a county level, the same data, I'll skip that. So how do we operationalize this? Well, for polio, we start out and we have our routine surveillance. We test once every couple of weeks. That's kind of our baseline. If we get a detection, we scale up our frequency until we get repeated non-detections, and then we decrease our frequency. So we have an adaptive surveillance system where we try to find the virus. And when I worked with the Syracuse University COVID reopening plan, I was working with Vice Chancellor Haney, and I drilled into him this idea that every time we found a COVID infection, we celebrated because we were finding the virus, and then we could stop that chain of transmission. And it's the ones you don't find that, if you're trying to eliminate a virus, that are problematic. Some of the other tools we're doing involves human movement. So say we have a new disease. This is based on polio. Let's say it's just measles, and we get a measles cluster in one of these communities. We can use human movement patterns to predict where it's going to go next. And with 3 to 6 weeks, give them advice about, hey, measles is coming, be prepared. And with 3 to 6 weeks lead time, You can arrange childcare for kids that are too young to get a measles vaccine. You can arrange to get a measles vaccine earlier than the prescribed schedule. There's a lot of different public health responses you can do with that much lead time. Wastewater surveillance is going to work for most every pathogen. We did a systematic review of the literature. All these different families of pathogens have been found in the wastewater. All these ones here. These blue ones, this blue square, are pathogens that have been considered infectious diseases of international concern. And then this gray square is the greatest burden of disease across the world. And already we know measles is detectable in wastewater, tuberculosis as well, malaria. I haven't seen whooping cough yet across the world, or in the wastewater yet. So back to the original, how do we make sure that we're safe, health security, free from disease? We need really good infectious disease surveillance. Wastewater surveillance is one pillar of that. We also need to sequence what makes us sick. Not everything, but some things, right? Of some proportion of our infectious disease cases, we need to sequence to understand what it is. We need better health system records. We need to move to electronic health records. A lot of the research is done in the VA, it's done in the United Kingdom, it's done in Scandinavia, because they have these systems where they can look back at COVID, or excuse me, just a minute. Where they can look back at the diseases and the exposures and make the linkages. And then one thing that we haven't figured out is contact tracing. I think about public health and I think about firefighters. I love firefighters. I want all the firefighters. I don't want my house to burn down. I love them. But we often pay them to do nothing. And for good reason. We want them ready to go if there's a fire. They wash the truck, they visit the kindergarten, they do what they need to do, but they're ready to go. We do not have that attitude with infectious disease. We have overburdened local health departments. We do not have people ready to go to respond to outbreaks. So we have to figure that out, whether it's somehow through the National Guard, somehow through a volunteer corps, something. Something has to happen around infectious disease. And that's all. So thank you for having me, and I can take any questions you might have.
Question and ask Dr. Just let me know. Yes. Bird flu has been around for a while now. It's starting to watch. And I haven't really paid much attention to it until today. I was listening to the radio and heard a report that a bird, the thunderstorm, which is now starting to migrate through here on this way up north, and I really like watching the migrations of the thunderstorm is taking a very big hit, according to today's news with the bird flu, and I found that very disturbing. And because it seems to be getting closer to home, I should be concerned about bird flu because of the other implications. But I was sitting until today when I heard the thunderstorms hitting it hard. What's your comment on bird flu? Where's it going?
Yeah, no, it's really devastating a number of species of birds. Influenza is endemic in birds. It so circulates within bird populations. Influenza also circulates within pig populations. Then it circulates within human populations. And pigs can act as the intermediary host between the birds and the humans, oftentimes with the different avian influenzas that we've had outbreaks into human populations. They get into the pigs and then they get into the humans. So any type of infectious disease circulating within an animal kingdom is of concern. We don't want it just to run rampant. Every time there's a transmission event, that virus is mutating. It's just a probability of whether it will mutate so that it can adapt to our cells. So our cells are different from the bird cells, and most of the time that avian influenza can't even get into our cells. It's just focused on the bird cells. So that's one factor, what's happening in the animal species. Another risk factor for the emergence of these avian influenzas is our interaction with that animal species. So how close are we interacting? High risk of playing with dead birds, right? You don't want to pick them up or handle them. But other than that, the risk is the birds get into our domesticated animals, either chickens or ducks or pigs or cows, and then we pick it up from those. So that's where some of the interventions are going is toward the domesticated animal space, because that's the intermediary for our risk profile. But it's something we're watching. We haven't seen an amplification of human to human transmission yet. The more we allow for transmission to go through dairy cattle and domesticated animals, the worse off we'll be. Every time it passes, it could mutate and get into the human population. So far we're okay. It's not abnormal that we see these pathogens in other animal systems. It is sad when we see, especially species we like, drop off. But it's not, I'm less concerned today than I was in November with bird flu. And then we'll see what the next year brings. So, I don't know if that's a good answer, but it's kind of where we're at. Yeah. And I will say that so New York State's wastewater surveillance system is part of the national wastewater surveillance system that's called the NEWS. The NEWS is testing for H5 avian influenza in the wastewater. The current understanding is those detections are likely contamination of where birds get into the wastewater, or the bird infection through feces gets into the wastewater, not through human infection. At the same time we do the wastewater surveillance, we have to do the clinical surveillance. So when people come in with a flu-like symptom, we need to sequence some percentage of those flu to see, is it an H5 influenza? And that is not showing where we're finding any H5 influenza infections, if that makes sense.
So I was curious where you see public reporting going, how you think you might be able to get to these populations, just thinking of like how norovirus is much more a problem issue than in past years. And it seems like you're gonna have some lead time to be able to let people know things are coming. So how do you foresee in 5 or 10 years people getting this information? What would you like to see happen?
Well, that's an interesting question. Thank you for that. I will say that the lead time is pathogen specific. And so for norovirus, you're exposed and you're violently ill for 24 hours, and then you're fine, all within about 48 hours. So biologically, we don't expect a lead time on an individual basis where we see somebody infected. They get exposed, they get infected, they start shedding incubation. And that's kind of like where we have measles, is with that longer incubation time. We might be able to pull out signals from norovirus in the wastewater to alert and say, hey, something's percolating here, it might come over. So that needs to be developed. But 5 to 10 years, I would love that if local health departments had greater understanding of wastewater surveillance data and used it to make public health advisories, that would be one. If maybe a pipe dream would be local news channels, in addition to having the weather, they show the infectious disease transmission profile, right? And say, like, here's the forecast for the next week. Wash your hands extra good this week. And then also that we would make progress against diseases we can eliminate, like measles, like these vaccine preventable diseases. That if we go looking for it and we find it and we get rid of those chains, interrupt those chains of transmission, we can start to get rid of it. So I'm optimistic 5 to 10 years from now what we can do. I think we'll be able to forecast a lot better, have better early warnings. We should have a better understanding of what's driving illnesses and the public health response. I think one of the big variables is what the public wants, right? Does the public want to continue investing tax dollars into these systems, and do they appreciate these systems? And that's more of a question right now for me.
So let's say we just promoted you as our local meteorologist. Based on the current data, what might you be forecasting for the next couple months?
The COVID-19 transmission has been really low, and that's confirmed in the wastewater. That's the one that we're watching the most closely. The influenza, RSV seasons, those are winding down, right? We're at the end of the flu season. And so now we're looking at a nice summer, I think, I hope. Avian influenza is on the mind, right? It is before COVID-19 influenza, pandemic influenza was the one that was the big one. That was the one that the epidemiologists were really worried about. So we got a coronavirus instead, which is not nice. Yeah. So we're not there yet to have it on the news, but we're getting close.
So we're seeing a lot of news about measles that are coming to the area. Is there any that was?
Yeah. So we're not in the New York State wastewater. We're not. There's no data that I've seen that's testing. That I've seen the testing data for measles. I think it's still an exploratory phase. Last year, 2024, I was in Austria, and I was working with their wastewater surveillance network, and they had a big measles outbreak in the state of Tyrol. It's one of the more mountainous states of Austria. It's in the Alps. And I think they had 124 cases of measles, which is a rather large outbreak for a small geographic area. And I was analyzing the data with them, and they had a signal of measles in wastewater 3 to 6 weeks before every community had a measles case. And measles is it's like a perfectly made virus for something like wastewater surveillance. I apologize if I've told some of you this before, but the measles vaccine policy, right? In the US, our measles vaccine policy is 1 year is your first dose. When you turn 1 year, you get the first vaccine. And then before you go to kindergarten, you get your second, about 4 years old. The reason we do it that late in age is because we think there's no measles here. The measles vaccine is licensed for up to 6 months of age, right? So you can get it as early as 6 months. And in countries where they know there's lots of measles, they do a 9-month and a 2-year vaccine schedule. So there's nothing wrong with our 1 year, 4 year vaccine schedule until we start to get more measles circulation. And so if you can think about, if we test the countries or states' wastewater, you keep your policies the same, your vaccine schedules the same. If you detect it in the wastewater, you say, hey, if you're a parent with a kid between 9 months and 1 year, not yet vaccinated for measles, we just found measles in the wastewater. Talk to your pediatrician about getting that vaccine a little earlier. Or if your kid's between 1 year and 4 years old, talk to your pediatrician about getting a second dose earlier. Or if you're a parent and you have these young kids that can't get measles vaccine, maybe think about isolating for a little bit until this measles passes through our community, because the outbreaks do not last forever, right? They're kind of like a fire. They burn through all the people that are not immune, and when there's not enough not immune people, then they die out. So measles, to me, because of the lead time, is a perfect candidate for something like wastewater surveillance, and it's the lead time plus the ability to intervene and to alert the public, and then the public is empowered to do something about what's coming.
So I apologize, I'm not going to go medical, but do you foresee that this model could be used as also for product?
Yes, yeah, very good question. So one of my students, he wants to look at biomarkers for cancers. Now, you have to think about the limitations of what this is. This is a community-wide estimate of something. And so what's the prevalence of a biomarker, a precursor for cancer? Can we align that with how much screening is going on? And could we do public health advising to say, hey, we're seeing an elevated rate of these pre-cancerous biomarkers. Make sure you're up to date on your screening, because if you catch cancer earlier, survival rates are better. The cost to treat is much lower. That's the good side. Now, the nefarious side is in the insurance schemes that might use something like this to say, all right, this community gets higher rates, this community gets lower rates because of these different biomarkers. But the amount of material in the community's wastewater is enormous. Biomarkers for cancer, all sorts of genetic diseases, everything is in there. So could potentially be used for good, but hopefully not for bad.
Will the homes cuts to help you with this impact what you do?
Yes, we're starting to see some of those impacts, right? So the most recent cuts are twofold. One cut is that they clawed back the COVID-19 supplemental. And the state departments of health across the United States are funded in part by the CDC through grants that are capacity building grants. It's called the Epidemiological Laboratory Capacity Grant. And that was supplemented with COVID-19 funds. And then their rationale is the pandemic's over, so we're going to take those funds back. Those funds were being used for things like updating infrastructure, improving data systems, improving or building up the workforce and population. So my team, I've already seen 9 people that were cut. Their funding was cut for our team. We're trying to sort through what that means and trying to bring them on to other things. So that's one way, and it's that those are impacting. The personnel cuts at the CDC and the HHS are devastating to very good scientists that are dedicated their lives to understanding health, public health, and how to improve the health of America. The infectious disease groups, the outbreak response, the epidemic response, they are less affected. And so from the HHS memo, they are focusing the role of the CDC to be responsive to epidemics and outbreaks. So we're hopeful that our work won't be as impacted than it already has been, but still quite frustrated about the loss of expertise from the FDA, the CDC, the NIH, the HHS in general.
Now, about halfway through your slides, you showed 1% sample taken upstream from the wastewater treatment plant.
Yeah.
Coming up upstream means.
Good question. So think about the wastewater treatment plant, that's where all the water gets collected. And to go upstream means you go up into the community through the sewer lines to take a sample from a lift station or a pump station or through a manhole. And so the treatment plant represents everybody that's connected to it. But you can go further upstream to find a smaller section of the community. And you might want to do that if you want to have a school level surveillance. So we worked with some schools here in Jefferson County to understand, well, what does wastewater surveillance do for schools? And could they use wastewater surveillance instead of all the clinical testing, and could they still get the same information? That's an upstream sample. For nursing homes for nursing homes, we could do similar things where you sample from the wastewater leaving the nursing home. It's not about picking up the disease from some of the inpatients, It's about the staff that use the toilets, right? And are they bringing the disease into the nursing home and the visitors? And so can you get an early indication that something is spreading in that nursing home and respond? And during polio, we did upstream sampling to try to understand how extensive the outbreak was. And so we detected it at a treatment plant. We cannot say whether it's in one community and not the other at that treatment plant. But if we go upstream, then we can test this community and that community and say it's here, it's not. And in polio, the upstream sampling told us it was everywhere. It had really spread, and there's a lot of reasons for that. There wasn't a lot of risk to the population, but it was spreading. That's what the upstream means.
I have a question about the upcoming flu vaccine. I read a report where this, I think it's in Dr. Paul Hoffman, and he had a team where he's working as an independent team member to determine the flu strains that, they're passed down every year, and then they create a bivalent vaccine for the upcoming vaccination that we have involved. Well, they were told by the FDA, or the Senator, that their services were no longer needed, and the FDA was going to determine what this new vaccine concoction would be. Do you know anything about that? And is that worrisome in terms of what this might have been like in the fall?
It's a good question. It's a good question. It is concerning to me. I don't know that I have all the information to be an expert on this. But I can inform a little bit about some of the international relations issues that the current administration is having with this America First or America Only policies, right? So the World Health Organization, one of their key roles is to monitor influenza transmission across the globe. New strains of influenza, for whatever reason, they kind of sweep east to west from the globe. They kind of start in Eastern Asia, and they sweep through, and they come and they hit our hemisphere in the fall. And so we can watch East Asia, Southeast Asia, and try to figure out, well, what's circulating and what's likely going to be here for us. That data is all collected and shared within the World Health Organization. So when we withdraw from the World Health Organization, we're one of 2 countries to do so ever. The other one was the USSR, I think, withdrew and then rejoined. And then Libya might be the other one. It's incredible that we would withdraw from this organization. Because, the reason it's incredible is because the donations we were giving that they cited as the reason to withdraw, those were all voluntary. So we could have cut our donations and still been a member. There are some member dues, but we were giving far in advance of those because of our generosity. So we withdrew. So my understanding of my colleagues at the World Health Organization is they will share everything they have. They want to control influenza. They don't they're not going to like hoard the data. They'll share it. But the CDC has been told not to talk with them. So there's a lack of access to data. And that's from news reporting, is the CDC has been told not to talk with them. I am concerned about the upcoming flu season. There are some really interesting evolutions in flu over the last 5 years. So our COVID-19 precautions were so effective at reducing respiratory transmission. Respiratory-driven pathogens, we drove one strain of influenza extinct. It's never been seen again since 2020, right? So that's pretty crazy how we just socially distance, wear masks, and that whole strain of influenza has gone extinct. Now there's plenty of other strains of influenza that will affect us. Some of those, like and influenza has 2 big genetic domains, the H domain and the N domain. So you have H1, H3, H5, N1, N2. You have all these different combinations. So the Paul Offit fellow, his team, my guess is that they would have been, if their services are no longer required, if that's what's being reported, they would have been a contract to work on that stuff and to do bioinformatics to understand and to make suggestions. Pretty sure we will have a flu vaccine, but I don't know. I'm nervous about it, actually. I might have looked how to get a flu vaccine across the border. I don't want to be a fear monger.
So are you saying, I'm sorry to are you saying there might not even be a flu vaccine?
No, there'll be a flu vaccine. The challenge with influenza is the virus mutates so much that it's hard to predict what's going to be circulating in the fall because you have to start manufacturing in the spring. And so it's a guessing game and use all the probabilistics and statistics you can. And then the loss of really good scientists and the personnel decreases our accuracy in predicting what will be here in the fall and how effective that vaccine will be. And America's not the only country in the flu vaccine space. So lots of scientists around the globe try to do this, and we'll see what happens, what the American vaccine looks like compared to others. It's a tough one. You know, our flu effectiveness vaccine, the efficacy of our flu vaccines ranges from 30 to 70% every year. It always is more protective against hospitalizations than it is against infections. It could be a low year, we could get it right. You know, after all this, they could get it spot on, right? Even a broken clock's right twice a day, right? And it's just who kind of knows. So it is worrisome, it's troublesome. And I'd encourage you to write the representatives and the senators and give them a piece of your mind, because that is one of my primary concerns.
You may have already answered this stuff. In the 200 processing units that cover 95% of people in the state, are these tests now part of their standard operating protocols of those centers?
No, they're not. These tests are now dependent on the voluntary participation of the treatment plan operators. And so they are completely voluntary. They're heroes. They send us a sample out of their goodwill. We pay for the shipping, we pay for the tests, but we rely on their voluntary effort to ship us a sample. We have lost, out of 205 we've enrolled, we've lost maybe 15. It's not been so bad. Recently, so we started this with Syracuse University and ESF and Upstate, and always with the understanding that this is a state public health operation. This is not an academic operation. Like science, academic science, we test hypotheses because it's fun and it's cool. Make discoveries because we think this might help humanity. Public health surveillance, we test because that's what we do, that's our role. And that belongs in state departments of health and local health departments who are responsive. They're part of the government system, right? They're responsive to the elected leaders. Academics, I'm a freewheeling academic. No elected leader can tell me what to say or not say. But the local health departments, the state department of health, they are the part of our democratic government. So we always wanted to shift the testing operations to them. It belongs to the people of New York State. It's not an academic exercise. We're in that process now, and that's where some of the treatment plants have begun to say, well, we had fun with your research project, Dave. We're going to stop now. And so we're having to do outreach, and we do a lot of outreach anyways, but trying to keep people in, keep these treatment plants in. We're doing okay, doing pretty good. So we're going to lose more treatment plants to budget cuts than we will to treatment plants saying we don't want to be a part of it. We don't give it to the public. So our response, if a treatment plant stops, our response is to ask them to reconsider. Then we talk to the local health department and tell the local health department it's a problem. So if you want to know if your treatment plant is still participating, talk to your local health department and say, just want to make sure this is still going on, and let them know that it's a high priority for you. And so Watertown hasn't stopped, they're still going. We had one treatment plant, the operator's like, we're done. And then we told the mayor, and the mayor's like, no, you're not. And it varies by treatment plants. Some treatment plants are owned by the city or the county. Others are owned privately and then licensed by the taxpayer, the county, and the city. And we've had the best luck we have is with we've never lost a treatment plant where the local health department still wanted it. Right? It's when the local health department says, we don't know what to do with the data, we're not interested in the data. That's when we lose treatment plants. And so a lot of my work, we're trying to build that capacity of the local health department. How is this useful? How is it helpful?
I'm 80 years old, so I'm old enough to remember my grandmother, who was one of the very first public health nurses in 1907, telling me stories about how she went around and nailed the quarantine signs on items for typhus, typhoid, all the things that you don't seem to see today. But it was a very scary time, and I had great admiration for my grandmother. I thought she was a real hero when she first public health nurses, working in the water camps up in the Olympics, healing their wounds and contusions and lacerations and everything. Tough work going on, horses coming out of this. Then polio. I was old enough to remember the days before it actually became assault. And it was a scary time for us kids growing up in the polio. My parents were very protective of us. There were a lot of old wives' tales and most times about what was causing polio, and I was subject to some of those old wives' tales. And I look back on them today, and I used to believe that stuff. But what's that help my memory was Dr. Jonas Salt the very first. Was that the very first vaccine, the polio vaccine? Did we have vaccines prior to that?
That's a good question. So the idea of vaccines goes back to Persia, Kingdom of Persia. They practice what's called variolation. It comes from smallpox. And so they would find somebody, and smallpox is highly deadly, right? Smallpox is a scourge. And I want to say it's 1 in 4 deaths or 1 in 3. It's so deadly. It's awful virus. It's been eradicated. It doesn't exist except in the CDC labs and the Russian labs. So if it does reemerge, it'll be a bioterrorism event. So I want to say the 17th century, they would practice this variolation where they would find a mild case of smallpox. And they would take some of the scabs of the smallpox, crush it into powder, and then give that to people. And that's a type of a vaccine, like an inoculation. That was improved upon by a fellow named Edward Jenner in the 1800s, 1700s actually, Edward Jenner. So the variolation in Persia must have been like 1500s or 1300s. So the late 1700s, Edward Jenner, he observed the milkmaids that they didn't ever get smallpox. He's like, well, why? They'd got what's called cowpox, and cowpox and smallpox were so similar in their structure that a cowpox infection would lead to immunity from smallpox. And so he started to take cowpox and inoculate people with cowpox. And there's a really great great political cartoon that this artist drew of people turning into cows because they got this vaccine, right? The fear of the vaccine is old, it's ancient. And it's understandable. The vaccine is really the only biomedical intervention we give to healthy people. We take perfectly healthy people, we give them a virus, right? Like perfectly healthy, we give them cowpox virus, and all because how deadly smallpox was. George Washington, he required the Continental Army to undergo variolation of smallpox. It's dangerous. It had a high fatality rate, even the variolation process. But that's the first vaccine. Jonas Salk, I love, he's such a hero. He was the first polio vaccine, his was. And he was asked, well, why don't you patent this? I'm sure it's worth a lot of money. And he said, how could we patent this? It's like the sun, it belongs to the people. And just a fantastic human. And yeah, polio is such an interesting case because it's terrifying. The risk of paralysis with polio is very similar to the risk of death with COVID-19. About 1 in 200 people, if they're not exposed to COVID-19, they would die from COVID-19. 99.5% of the people survive COVID-19, but that means 1 in 200 die. With polio, 1 in 200 infections leads to paralysis. 99.5% of the people could get polio and it's fine. But it's just that 1 in 200 that get paralysis. And so why is polio so scary? Where the memories of it invoke a time where we were so grateful for that vaccine to free us. You know, they closed the swimming pools during polio. They closed the schools during polio. It's very interesting to me, that comparison, because they are so similar in their risk profiles, and yet they evoke such different feelings about what should be done about these viruses. So, but was it your grandmother? She sounds like a hero. She's awesome.
She's a hero. 1907.
Yeah, that's cool.
We've got some of the diaries.
That's a treasure. Yeah, those are treasures.
Do they still use iron lungs today? I had a couple of relatives who were in iron lungs. Is that still a treatment? It seems so barbaric.
Well, the iron lung was necessary if the paralysis got to the diaphragm and then it helped you breathe. I actually don't know. I don't know. Yeah. They do need something. I'm not that kind of doctor. I'm not a clinical doctor. They do need something if it does get into that diaphragm muscle. Then they would need something to make sure somebody's breathing.
I remember my mom and dad, crazy, probably doing salt. I was just a little kid. My sister, we got vaccines in school.
Lined up for a sugar cube. Yeah.
It was like this wonderful gift.
Oh.
My parents just were so ecstatic.
Yeah. And that's the same way that I felt about the COVID-19 vaccine. I was ecstatic to get it. And I was so happy to get my kids to have it. And then like, for me, I think that the emergency ended once the vaccine was available. That was really, to me, the end of the COVID-19 emergency. What happened is we ended the emergency to COVID-19 after Omicron. And Omicron is like a whole nother virus. It's so much faster transmitted. It's so much harder to control. At SU, once Omicron hit, I called the vice chancellor and I said, we're done. We cannot control this. And we couldn't control it not only because the virus characteristics had changed to become so much faster, but the people were sick of it. The people were sick of not going to parties and wearing masks, and they were tired. So they weren't going to adhere to these non-pharmaceutical interventions, right? And that was basically the time when America said, all right, we're done. COVID emergency is over. In hindsight, I wish we could have had an ending of the COVID emergency once we had the vaccine available for all. And I think that would have helped a little bit some of the inflammatory feelings from the pandemic, because really that pandemic emergency dragged on and on and on. You know, my kids were out of school for like a year and a half, and it sucked. Yeah, it was rough. Zoom school is an abomination for young kids. Like it doesn't work.
I don't think this thing is working, but I'll just speak louder. You mentioned electronic health records at one point as an important part of surveillance. Is that right?
Yeah, important part of our health security system.
And then you mentioned was it veterans that you focused on specifically for the EHS?
a couple of studies, right? So it's a couple of, they're called observational epidemiologist studies. They've used the electronic health data from the Veterans Affairs, the Veteran Hospital System, to try to understand the linkages between different risks and diseases, right? And so they were looking at, if asking the question, well, does a COVID-19 infection make you more susceptible? Does it harm your immune system, make you more susceptible? And the answer they came up with their study was yes.
So you didn't use veterans in that particular data track? Question. Did you use that because veterans can move from California to Watertown here and there, and they're using the same EHR, so you can kind of follow them?
Yeah, so I don't work with these aren't my studies. But that is the reason that the continuity of the record and the completeness is one reason that this makes it a very valuable population to study. They're similar ages and exposures and all of that. So they're similar cohorts, makes them valuable. They have really good access to healthcare relative to the general population. That makes them a valuable cohort to study. And that's where, you know, with an epidemiologist's dream is a health system where everybody could go to the doctor anytime they wanted, and it just produced loads and loads of data. And we can just mine all that data, do all these analyses, try to understand what's the linkages between all these different health outcomes, communicate that, and then let the people decide what they want to do about it, right? So.
So,
Yeah.
David, thank you so much, and I think I'm safe to say that if anyone has any other individual
I'll
questions,
stick around
for
if
Dave,
anybody wants to
thank you so much.
Yeah, thank you for that. Thursday night.